Hello, my name is David Rhew, and I am the Global Chief Medical Officer for Microsoft. I'm a physician, a technologist, and a health services researcher, and I've spent the past 25 years looking at how technology can be used to improve health outcomes, specifically access to care, quality of care, patient safety, finding ways to remove waste from the system and improve the overall efficiency, and improve the overall experience for both patients and providers. I'm also an ID doc, and at the start of the pandemic, I was appointed as Microsoft's international coordinator for the COVID response. We began working with countries across the globe to understand how technology could help support them in their effort to battle the disease. And one of the first things that we recognized was that organizations across the country, including NGOs, had diverse needs that required us to pivot very quickly to address them. Additionally, we learned that data was incredibly important in allowing us to understand where to direct our efforts. First of all, knowing where was infections occurring and where the resources were. The World Health Organization is one organization that has been looking at pandemics and epidemics for many years, as well as other disease surveillance. What they found was that they had antiquated systems, systems that were largely based on paper and other types of tools that really didn't talk to each other. And what they were looking for was a common data platform that would allow them to be able to be much more efficient and effective in their ability to provide support to the member countries that they were working in. And what they found was that in order to do this, they had to rebuild their infrastructure. Microsoft, partnering with Avanade, began that journey with the World Health Organization during the pandemic, where we started to look at how could we build a single data platform that would allow us the ability to be able to pull data from different sources and allow us to be able to provide analysis. Now, this project has been continuing on, and today we are now recognizing the potential opportunity to apply this type of single data platform to address the 3 billions initiative that the World Health Organization has set forward. That's essentially improving the lives of 1 billion individuals to enable increased access to care. Another billion individuals for whom we can address medical emergencies, such as pandemics, and another billion to address the issues that we see oftentimes related to everything from one's health, the environment, and how we can improve upon that. As we started to learn that this type of data approach allows us to be able to better understand the needs and be able to be much more efficient, we have also taken a closer look within the countries and tried to understand how can we be helpful. And in looking at what countries were doing as we started rolling out vaccinations, we realized that the first phase was how can we provide an infrastructure that supports mass vaccinations. Largely one of the biggest issues was that there actually was too much demand initially and not enough vaccine. And because of that, systems were getting overloaded. We were seeing that many times the systems were crashing because of the fact that too many people were hitting the system at the same time. And for registration and scheduling, we were unable to be able to have this function on a continuous basis. So we had to upgrade to the cloud with greater capabilities, compute storage capabilities. And that gave us more flexibility also to be able to deploy in other settings, to be able to stand up and stand down these type of systems. And that allowed us to be able to then move to the point where we had both capabilities for mass vaccination sites as well as pop-up clinics in schools, churches, and parking lots, and everywhere in between. Now, as we've been looking at the pandemic, things have evolved, specifically in developed countries where the vaccine has been made available. One of the things that we've recognized is that as the vaccine has continued to be deployed, more and more individuals that had wanted the vaccine have now received it. We're now hitting to the point where a lot of individuals had been on the fence and had questions and concerns about that. And this ties into an aspect of healthcare that we have known for quite some time, that there are groups that have always had questions about the validity and the trust that they should have within the science and the scientific processes and the individuals that are within the government. And because of that mistrust or lack of trust or diminished trust, we've seen some hesitancy towards wanting to adopt the vaccine and any other types of scientific experiments or scientific interventions. And what we have now recognized is that it's not just about providing the vaccine to them. but we had to go one step further. And this gave us an insight into how we need to better address health equity. Health equity is something that we know relates to the disparities of care that exist between individuals, oftentimes between different groups, maybe ethnic groups or regional groups. And what we've now recognized is that simply making it available is only the first step. The next step is making it easily accessible. And so when we think about making things easily accessible, we're oftentimes now to the point of standing up those vaccination clinics in the mobile clinics, as mobile clinics or as in churches and in other parking lots. But that wasn't good enough as well, because it doesn't matter if you've got a stand-up, if you've got a vaccination clinic in your parking lot or in your backyard. If you don't have trust into the system, you don't trust into, you have a lot of questions, you're not going to go there. And that's really what was happening. And so that last piece, which was around a conversation that needed to be had by a trusted member of the community with an individual who may have interest in it, but really needs to have that discussion. And that has given us a greater insight that a key missing piece to health equity is engagement at the local community level with individuals that work very closely with the community. And those individuals have to be empowered with the tools and the resources to be able to deliver healthcare services. That means partnering them with the public health and the healthcare organizations and being able to allow them to be able to not only have those conversations, but to deliver the vaccines and other health services that were missed during those opportunities during the pandemic. And the data that's captured has to also be secured and then brought to the necessary places, whether they're immunization registries or the electronic health record. And this has to be done seamlessly. And what we realized is that there's three components. You've got the community engagement, you've got the public health and healthcare, and you've got the technology platform that underlines it. Now, we tested this in many places throughout the world. And what we realized is in underserved communities that oftentimes what we were able to achieve was something that we couldn't have achieved without all three pieces working together. Working with rural farm workers, many of whom were hesitant about the vaccine, but mostly because they were concerned that the data that was being captured could potentially identify them as someone who was maybe not there with all the proper paperwork and perhaps could lead to immigration issues. And because of those type of issues, what we saw was a huge hesitancy. And what was the key factor in enabling us to be able to address that was talking directly with some of the people who enabled them to be able to attend these. These were the workers. These were the owners of the different farms, encouraging them and allowing them the time to take off to get vaccinated. And then what we saw in several of these events, these were events that were not focused just on COVID, but were focused on just generally general health. Many things were done. Testing for COVID was done. Identification of other types of conditions that might have been missed, blood pressure screenings, diabetes screenings, and a variety of other things. And what we realized is that we could accomplish a lot more by meeting with them during these events. And additionally, as these events continued to move forward, this follow-up events, we would see 2 to 3 times as many individuals come in. And it was because they were inviting their family and their friends. And that was something that was incredibly powerful. What we also have seen is that in other communities where it wasn't just about healthcare providers and local community leaders, but it was individuals who we hadn't even envisioned as being part of the conversation. In some parts of the community, the trusted sources of information were coming from beauticians and barbershops. Sometimes it was coming from religious leaders, and we oftentimes needed to find ways to empower them with the right information so they could deliver those messages, but then also combine that with the healthcare system. And as we've gone down this path, what we've recognized is that there's a process for how we can start looking at how we address health equity. Health equity, again, starts by making the necessary services available. We then move to the next phase of making it easily accessible. And then the next part is the engagement. And the engagement is so critical because it involves the human touch. But at the same time, there's an underlying platform that supports this. And that underlying platform allows the data to be moved from these conversations into the appropriate places. And it couldn't have been done without collaboration from key stakeholders. I've mentioned before, you've got the community, you've got healthcare and public health, and you've got the ability for us to be able to bring them all together. The data underneath it has to be made secure, interoperable, and intelligent. And in this context of developing public-private partnerships to address health equity, to service the underserved, the vulnerable, and those that need healthcare the most, we've realized that this is a model that can be applied throughout the globe. And we are now starting to see this being applied in areas that are in different stages of the pandemic. But all the while, we're recognizing the value of the human touch combined with data. Thank you very much.